Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community. All right, hello everyone, and welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Doug Maynard, your host for the next hour or so. And Spark Live is where we gather each Wednesday to curate and convene and showcase excellence and innovation from across the child and youth healthcare community, with our goal, as always, to spark conversation, ideas, and action. And since we are live, I do want to remind everyone that you do have the opportunity to ask questions of our presenters. And you do that by typing them into the question box. And I encourage you to type those questions in as you think of them at any time. Don't feel you need to wait until the end when our presenters ask if there's any questions. Just go ahead and type them in as you think of them. And you can also feel free at any time to share your thoughts on Twitter, and be sure to tag us at Child Health Can. All right, so today we're going to be talking about the development of patient-reported measures of medical technology and feeding for children in complex care. And this is a great opportunity to bring some familiar and maybe some new voices to our webinar presentation. Our two presenters today come to us from the world of complex care. And first, we have Dr. Nora Fayed, who is an assistant professor of occupational therapy at Queen's University, and she has a research program focused on the measurement and prediction of child-important outcomes such as child functioning, quality of life, and well-being. And she also co-leads a patient engagement evaluation for Complex Care Kids Ontario. That's a provincial organization here in Ontario. And joining her is a familiar voice to many out there, Dr. Natalie Major, who comes to us from the Children's Hospital of Eastern Ontario in Ottawa, where she is the medical director for the Complex Medical Care Program at CHEO. And she's also an assistant professor of pediatrics at the University of Ottawa. And most importantly, she was also one of our co-chairs for our recent community of practice for children with complex medical needs, and participated in the development of the guidelines that at the time CAFC produced back then. So it's a great pleasure to welcome both of our presenters today. And first off, it's my pleasure to hand the virtual podium over to Dr. Nora Fayed.
Thank you. Can everyone hear me okay?
Yes, we can.
Okay, great. So as Doug mentioned, my background is in occupational therapy, and on my research hat that I wear, I'm really specialized in outcome research and outcome measurement, focused on children and families, and I have the privilege and joy of spending my time developing tools and studying outcomes for children with medical complexity as part of what we call the CCKO evaluation team. Dr. Major will tell everyone a little bit more about the CCKO evaluation and the intervention and all of the aspects of context around the development of these tools. Before we get started, I'd like to acknowledge our funders, of course, and tell you a little bit more about what we're hoping to do today. My personal objectives are just to provide everyone with a rationale for why we think we need to develop these tools, discuss the progress progress so far of how far we've come. We've made some really great progress, but we have a long way to go, and we need to be tied into a community of families and a community of providers in order to keep going and thriving with what we're doing. And we've also learned along the way how important it is to seek feedback when it's key decision-making time. And as a researcher, I think my point of view on what a key decision-making time might be a little bit more detailed than it is for others. So if it is, I apologize, but I think you'll understand a little bit more as we go. So on that note, I will turn it over to Dr. Major.
So thank you for the introduction and the opportunity to participate to this presentation and this work. So this CCKO evaluation. First, I will come to explain more about the CCKO, but what we wanted to reflect here is in the development of this evaluation process, we had a great contribution and participation from a large group of individuals with different backgrounds. And as part of the team that you see on this slide, we have representation coming from clinicians, from researchers, from families, as well as other team providers like occupational therapists, and everyone has brought forward a contribution to the development of an evaluation tool. Next slide. So the CCKO stands for Complex Care Kids Ontario, and I thought I'd explain and frame a little bit what this initiative is about for individuals who may not be aware about the CCKO. So the CCKO is an initiative. It's a provincial initiative housed within the Provincial Council for Maternal and Child Health. And as an organization, they are part of Ontario representation to strategize on priorities and care delivery for pediatric. And in 2014, they had put together a committee that was called the Integrated Complex Care Advisory Committee, which provided over the course of a year or so strategic direction for a province-wide care coordination plan initiative to address care delivery for children with medical complexity. As a result of this committee, the PCMCH approached the Ministry of Health and advocated for a provincial initiative for the advancement of the integrated care delivery and care coordination. And this resulted in a positive outcome where the PCMCH was mandated to, over the next 5 years, provide a platform for the implementation, expansion of care coordination for children with medical complexity. As part of the population, we know that in Ontario, there's a pediatric population represent about 4 million children. And of this 4 million population, there's a very, very small group which through work of Eyal Cohen and Astrid Gutman, they've identified that there was approximately 6,000 children that met the definition for children with medical complexity, but also defined as medically fragile and technology dependent. This group of children actually represent about a third of the healthcare spending for the whole of pediatric in Ontario. So they are, as we recognize, a high user of the healthcare system. So the mission of the CCKO is to develop a province-wide access to integrated care and coordination for children and youth who persistently demonstrate the most complex medical care needs. And this was as a result, 4 different centers were put together at an implementation table to develop the strategic planning of the complex care across Ontario. As part of the group, there was a development of an evaluation platform, and as you can imagine, there's multi-level of evaluation that were required. As the program developed, it was recognized that we needed an evaluation for assessing implementation of the program. There were programs that were already existing where we were looking at expansion, development of local initiative as well as satellite program, and we had also programs that were just recently implementing, and we needed a common assessment of these implementation process. As well as a new initiative for providing care to this population, it was important to evaluate outcome measures for specifically the type of intervention. And some of the identified strategic outcomes that were identified by the group were, as listed on this slide, to improve child, youth, and family experience and outcomes, to improve the collaboration and communication between the providers, and as well as to improve system efficiency, effectiveness, and sustainability. Next slide. As indicated, this is a province-wide intervention. There was representation all along from not only the tertiary care hospital, but all pediatric healthcare organizations in the community and around the community in the hospital that were involved into the development of this strategy and contributing. As the initiative evolved, there was a different initiative that further evolved, including the one that Nora is leading in identifying and focusing on this population and identifying the important outcomes from the perspective of the children and their families. And the hope is that as this project evolves for this specific population that are the highest user of the system, we also hope to expand these outcome measures once identified and developed and extrapolate them to the bigger group, the bigger population who also are part of these children with medical complexity, and also maybe to a bigger population.
Thank you, Natalie. So as Dr. Major mentioned, what we know that the implementation of CCKO in the first wave is really focused in certain strategic sites, but we also have been thinking through the process of our evaluation what we can do to create things that providers and families can use, even if they're not involved or connected with one of these centers or one of the places where implementation is taking place in the first wave. So I'll talk to you a little bit more about that. But really, how I became involved was as an outcomes researcher, being approached by members of the team on what the best way was to evaluate the care. So I think Dr. Major highlighted very nicely kind of those high-level outcomes that they knew at the beginning of the implementation as a group. They wanted to look at the experience of care and that they wanted to improve outcomes for children and families. However, then it came time to choose the specific outcomes and the specific tools that would collect the data on those outcomes. So the question became, what would be the best way to evaluate care? And from my perspective as an outcomes researcher, I've come to answer that question with another question, and maybe it's a bad professorial habit to answer with that depends, right? So it depends on who you ask. So among communities of families of children with medical complexity and their providers, and there's just so many stakeholders, and the level of interaction that stakeholders have with each other in this community is truly remarkable. So the families are interacting with service providers at a very high level, and consequently there's these pretty interesting integrations between service providers, families, and even policymakers. But traditionally, if you ask a policymaker what they need from an evaluation, they'll say we want evaluation tools that tell us whether the interventions are not just effective, but if they're being delivered as efficiently as possible. And that can often be manifested as just looking at service utilization in isolation in the absence of being able to track other metrics. So for example, policymakers often want to see how many in this particular population, how much ER use is taking place, or the length and the frequency of inpatient stays. Those are really strong indicators of service use or engagement with the healthcare system. But having said that, the PCMCH was really interested in knowing, having a more complete picture, right? The clinicians we anticipated were going to need evaluations that told them what types of children specifically need what kinds of help, and they wanted to know if they were having, through their interventions, a positive impact on people and how much, who they were really reaching and who they weren't, okay? And then from the perspective of children and families, we anticipated that they would want to know where they stand in their kind of healthcare journey, and they would want to know that from their care providers, and they would want some informed information about the health and well-being of their child today, but also what that would look like going forward. Okay, so our policymaker, here we are, we have this policymaker, they're supporting the evaluation, but they're not dictating what the outcomes would be. And healthcare providers giving us feedback, and families also. So how did we go about doing that? We solicited input. So it started with a survey. The PCMCH was very helpful in disseminating the survey, and it went to frontline providers, but also managers, anyone who was involved with service provision for children with medical complexity, and their family. And what was really remarkable, it wasn't just remarkable that they supported this without influencing it, but it was also remarkable how quickly we got it done. So I recall we made the decision to do it, and we did some qualitative work, and we got the tool, the survey up and running in a very short period of time. And the survey was designed to elicit what people's priorities of outcome were. So we could have just collected a whole bunch of mean scores and decided on the outcomes in that way. But we really wanted to make sure that we were getting a good sense of what people's priorities were. So we did a lot of subgroup analyses. And what I mean by that is we did rankings of outcome priorities for all these different types of families. So we did a list for families of children who were 2, school-age families, teenagers, and then people in transition. Same thing for the health providers. We looked at what the priorities of managers were, what the priorities of physicians and pediatric subspecialists, as well as people involved in rehabilitation, such as occupational therapists, speech pathologists, and so on. So we really had many permutations of of outcome prioritization. And we were able to take those top priorities and just say, you know what, if everyone says these outcomes are important, they're just going to be in the evaluation. And everything else that was kind of a gray zone or didn't have kind of perfect agreement across all these subgroups, we discussed in a consensus conference. That presented us with this wonderful framework. And when we got to the framework, here, I'll just get to show you our framework right here. This is what we ended up with after the survey and the consensus. So it's interesting because empirically things ended up being organized along those high-level outcomes that Dr. Majol outlined earlier before we even got started on this prioritization. So this framework has as the most important thing that needed to be studied in order to determine whether this implementation was working was around the experience of care. And that's what you see here, focused around service delivery. So for children with medical complexity, a good experience of care, we found out, as perceived by families and frontline providers, would mean that care was being coordinated well among providers and among the providers themselves, but also between the providers and the families, and the care planning tools were of good quality, and that they were useful for doing what people needed them to do. And that's good that this was the information coming forward around what we needed to evaluate, because it maps on to the implementation. It maps on to some of those key areas of what they were hoping to implement. Also, with regards to positive outcome, the most important outcomes for children and for parents or caregivers was around these broad things such as quality of life, and for the child, the emotional well-being of the child, and for the parent, how they're doing in terms of their physical and emotional health. There are more specific health outcomes that we needed to focus on with regards to the parent, and that included their energy levels and their fatigue. For those who provide service to these families, I don't think any of these outcomes will come as a surprise to you. But what was particularly wonderful about this is that we were not just another branch of the evaluation that was looking at health utilization was really going to be rounded out by this information, because we were also told by the stakeholders that we needed to track the out-of-pocket expenses that families were spending. So it really kind of rounded out the evaluation to tell a complete story, not just of spending in terms of healthcare spending, but also individual families, what they're spending. For the child, we were told that we really should be assessing the child's level of physical pain, that outcome should be improving as a result of intervention. Okay. There were two outcomes that we were not able to find measurement tools for that were satisfactory to our purposes. So the feeding and swallowing that you see there was really going to be conceptualized. We knew that there were clinical outcome measures for these things, but we also needed to know how families were doing with it, how they perceived they were doing with feeding their child, and how their child was eating on this kind of broad level. And we definitely did not find very good measures that we could use to assess how the children were doing with their, or how the caregivers were doing with their child's medical technology. So we are aware of measures that assess satisfaction with assistive devices, but we weren't able to find a measure of medical technology. So in this group of children and families. Maybe Dr. Majol, you could tell us a little bit more around some of the types of medical technology we would see.
Yes. So the technologies can include anything from a tracheostomy, some ventilatory support, to a G-tube, a central line. We will at times include suctioning, monitoring device, especially in children that requires very close monitoring day and night, to a cochlear implant and so on. So,
thank you. The other thing that I'd like to draw the attention of our audience is to the types of outcomes. If you look at this framework, it really has a lot of things that can only be measured by asking families. So, for example, quality of life, emotions, the impact of a diagnosis on the family's day-to-day function, those are not things that can be easily observed in a clinical situation. And I think most providers are used to asking families, how are you doing, quite generally. But many of these outcomes needed to formalize and quantify these specific aspects of how people are doing. And so the way that researchers go about doing that, collecting that information, are through these tools called patient-reported outcome measures or patient-reported experience measures. And we call them PROMs or PREMs for short. So PROMs and PREMs are scored questionnaires that measure how a patient is doing without any interference from a third party. Okay, so patients complete questionnaires, they get a score, and that score has a lot of scientific validation behind it. So no one can change the score. When we ask people, how are you doing? How's your quality of life? How are your emotions? How well do you perceive that your care is being coordinated? The patient filling it in provides their honest rating for those questions. And there's an algorithm behind the addition of the numbers. It spits out a score. And so truly the only thing that ends up influencing that score is the patient's assessment of how they think they are doing. And after that, no one can touch it or change it. So really, if you look at the experience of care, we have patient-reported experience measures that are looking at experience of care. We also have some more objective measures around how well care is being coordinated, but we are enhancing that with their perceptions as well, because it really adds. So the plan is to develop tools that look at people's experience of feeding their child and how they're doing with the medical technology. A lot of it has to do with medical technology at home. But before I get into very detailed information about the development of these tools, I just kind of want to zoom back out of just a focus on our group and talk about what the importance is of these PROMs and PREMs are on a much larger scale, both internationally and nationally. So these tools have been identified as so important to health system improvement throughout the entire world, pretty much anywhere where there is a health system. The Organization for Economic Cooperation and Development, the OECD, has put together a working group to look at their importance to social and economic growth internationally. And there's already some questionnaires in there that are very similar to patient-reported outcome measures, such as things like life satisfaction. In the United States, in 2010, they passed the Patient Protection and Affordable Care Act, and they decided that using patient measures would be very important for ensuring the accountability of healthcare. The National Institute of Health in the United States, as part of what they call their NIH roadmap, decided that tools were very important to moving forward in the areas of progress for chronic disease care. And went through a very big, large-scale process to figure out what outcomes needed to be measured universally across healthcare services for Americans, and they developed tools, PROM and PREM tools to assess that. So if you go on the NIH website, they have those tools and you can see them. They assess these very kind of broad domains for adults and children. One of the downsides to those tools, they're called PROMIS tools, is that when you fill them in, the data sits on American servers, and they're validated on American samples. But really, the tools themselves are so powerful and impactful in terms of decision making and in terms of assessing healthcare and healthcare services that the Food and Drug Administration in the United States and the European Medical Agency started regulating their development, in particular for use in clinical trials and medical device claims. And I think that's a very good thing, actually, as someone who's connected to PROMs and PREMs. The difference between a good one and a poorly developed one can result in inappropriate conclusions if they're not designed well and they're not representative of the patients who they're assessing, right? So trialists and interventionists can stack the deck in the wrong direction if a tool is being selected that is not really representative of what people need or in terms of their healthcare. So that brings us to Canada. In 2015, CIHI and StatsCan identified the need for PROMS data to support kind of a range of healthcare goals as a high priority. So CIHI typically tracks health information from hospitals. It's really objective around mortality and safety, but they know that PROMS are really going to enhance the picture of how healthcare services are being provided, especially for people with chronic problems. So they honed in on some priority areas to get started, and that those were hip and knee replacement, mental health, and renal care. But these are all adult areas. I do want to talk about renal care, though, because I think it's the most relevant to us here who are interested in children with medical complexity. The reason is that chronic kidney disease affects about less than 1% of adult Canadians. The prevalence of the disease is rising, and there are very high healthcare system use and social supports needed to manage renal disease. Sound familiar? So that essentially is a description of children with medical complexity. How did the renal disease community deal with it? I'm sure they've made significant advancements since the last time I checked, but I was aware that the British Columbia Renal Agency and the Ontario Renal Network and even other provincial care networks were working together to identify common PROMs and PREMs that they wanted to not just use, but implement and streamline into routine care for the evaluation of that care. And they did that, and as a result, they have a basis for identifying regional gaps in their services and regional strengths, and advocating for tailoring of services across places and where they're the most needed. And I think that is the ideal scenario. That's what you are hoping for on this kind of high level. So among children with a medical complexity, their families and providers have told us that we really need to get better at understanding and evaluating care. And so we are hoping that the PROMs and the PREMs that we are developing are a small piece that add to this puzzle and will help us know if care is causing the bar to change in ways that are meaningful to the children and their caregivers. I think maybe now I will just check in with the group before I get going. Doug, perhaps?
Yeah, no, there haven't been any questions quite yet, so
Okay.
Feel free to continue, but that's my chance to remind the audience, do type those questions in at any time, and we may take another break, otherwise we'll just go through the presentation and take them all at the end.
Okay, so here's the fun part for me. I get to tell you what we've done so far. We have started development of the patient-reported outcome measures along how caregivers are doing with feeding, how the children are experiencing feeding, and also medical technology. The first step in doing something like that is our qualitative interviews. Recall I mentioned how important it is to get the information or the questions in those tools to be very representative and to come from the group that you're measuring. So qualitative interviews are a very, very important part of that. So we got started doing it the traditional way, where we had professionals interviewing families, interviewing caregivers. And on our team, that looked like occupational therapists who are expert in the area of feeding and expert interacting with these families and these children, conducting the interviews, and also occupational therapy students who are trained in doing these interviews as well. And the interviews are not prescripted. They're pretty open-ended. For us, they tended to be around, why don't you tell us about a good day managing your child's G-tube? Why don't you tell us about a bad day with managing your medical technology? What does that look like? What made it bad? What made it good? Same thing for feeding. We were pretty open just to promote that conversation. We didn't have preconceived notions of what that looked like. And through the course of doing those interviews, we got some information around how difficult a task this was and how sensitive some of these things were to families. And so we thought, maybe we could have caregivers talking to other caregivers. So we went out and recruited some caregivers to be members of the research team. We trained them on qualitative interviewing, but we tried not to be too prescriptive around the conversations that they had, and they really are started collecting data, and they are still doing that. So far, we have 26 completed interviews, and we're hoping to get to about 35, 40. We are in the process. We have now people, we used to get referrals from traditional sources, but we are now having families come straight to us through our Facebook page, and we can talk to you a little bit more about that also as we go. So of the 26 people that we have interviewed, we've got a range of caregivers of children who are 2 to 19 years old. That's what we were hoping for. All the kids who are involved have enteral feeding, and you can see the breakdown of what type of feeding they get. And there's also other medical technology involved in the group. One of the things that I am hoping to promote is a conversation around, well, how do we represent the families and all the types of medical technology that should be involved in this tool, right? So we clearly have a lot of families of children who are managing G-tubes, but we don't have as many families who are managing ventilators at home. So if you know people from these areas where we have less representation, then perhaps, and if they are interested, they can check us out on our Facebook page, and also have contact information for connecting with us at the end of the presentation. Okay, so maybe I'll just keep going, and once I've gotten through some of our very preliminary results, I'll check back in with the group again. So these results really are preliminary. They're not final. They're just to promote some kind of discussion and connection among this community. So with regards to feeding, you can see that the kind of domains or themes that are coming forward are really around these psychosocial experiences as opposed to objective performance of feeding, which can be assessed clinically. So I'll start with family. It has to do with, how the child's feeding habits and routines and the family's feeding of that child impact the family, family routines and excursions and so on. how that plays into the child's interaction with their peers, also at daycare and at school. Sometimes having special feeding needs can really complicate a child's school day or their experience at daycare. The child's experience is around looking at things a little bit from the child's perspective. So does feeding hurt? Is feeding emotionally difficult? Is it frustrating? Also some things around just their health with respect to feeding and their emotions. Being in the community is about whether the way the child is fed or the way the child eats can impact the extent to which the child can be in the community. Health supports relates to the supports for the caregiver to feed the child. So those are health supports at home, but also they could be professional or paraprofessional supports in the school for feeding the child. So that could be feeding via G-tube, but it could also be around feeding, getting taste by mouth or doing some other forms of feeding by mouth. And the last one has to do with caregiving self-efficacy. And that is less around a technical, it does include technical competence of feeding, but it's more focused on how does the caregiver feel about their technical competence with feeding. So do they feel that they know how to troubleshoot through issues? Do they feel that they know how to align their reactions with their child's needs? Do they feel like they know what to do if their child has different cues or different demands? Basically, it relates to their self-efficacy for that important caregiving job. Really similar themes have come out of looking at medical technology. And again, these themes are not final. There's so many different ways of organizing the data, but these kind of overlapping way between the two areas I thought we would talk about today. So impact on the family was really, really big deal with medical technology. So people were talking about how their entire family routine has completely changed as a result of medical technology, or how it's been organized from day one around medical technology. And sometimes those things could be pretty tolerable, but other times impacts to the family's sleep or other areas could be really problematic. Medical technology from children could sometimes facilitate peer interactions, but sometimes it hampered peer interactions as well. The child's experience, very similar to feeding, was around things relating to pain associated with medical technology, but also the health of the child as a result of the medical technology, whether it improved or not. Being in the community was also heavily impacted by medical technology. Were caregivers able to manage the med tech and go out, be mobile, drive around, go to different places, even have vacations or those kind of like higher level community things? Are they able to get out, or are they confined to home? Health supports was a very big deal. It wasn't just about the amount of health support, but the level of skill of the people who were supporting families in managing the medical technology, and the level of coordination associated with that skill. And it really highlighted for us how differently people experience these things, and how important it is to get interview feedback from people across different geographic regions and with different levels of interaction to coordinated care services. And then, of course, the last one, again, relates to caregiving self-efficacy. Do families and caregivers feel like they know how to troubleshoot through med tech issues, that they can manage the hygiene and so on and so forth? In discussion about some of these domains on the team, some really key conversations have come forward. One of the conversations that Dr. Major and I had yesterday was around the difference between people identifying their own level of self-efficacy and their own perceptions with managing medical technology versus what they are actually doing. And so before I open up the discussion to the group, I'd like to highlight, and I think Dr. Major would agree, that this is really not designed to be to replace clinical assessment. It is designed to formalize and quantify how people feel they are doing, which is an added piece of the puzzle to complement clinical assessment. So on that note, I'll open up some questions to the group.
All right, thank you, Nora and Natalie. Great presentation, and really highlighted that opportunity to get more information from the patients themselves to better understand their experiences as they deal with this. One of the questions that came in as you were going through the preliminary results was Marion was asking if this process would also obtain feedback on mobility and communication devices.
Dr. Michelle, if it's all right with you, I'll answer that. This is Nora. So we know that there are tools that look at people's satisfaction with their mobility devices when you're just looking at the mobility devices. So those are things like there's a scale called the PIADS. There are other scales that look at how you feel you're doing with your wheelchair or your walker. I don't know about scales that look at your level of satisfaction with augmentative communication. Not everyone in this population uses augmentative communication. So that's probably why it didn't come forward as one of the top outcomes that was important to all the subgroups. Having said that, we are getting a lot of data that's layered within these themes around the interaction between the child's medical technology and their other mobility devices, right? So, how the child's G-tube and equipment can work with the mounting of the wheelchair, or which wheelchair fits into the van, or which packs can be mounted on the wheelchair. There's all kinds of interactions going on there between the medical technology and the other assistive devices that can really limit getting out. It's not just the medical technology in and of itself. Don't know if I addressed that.
No, I think you did, absolutely.
Yeah.
The next question that came in was asking if you are able to share the tools you used for service delivery and quality of life outcomes.
So for the implementation, we took some, we published the framework that I showed everybody. We published that, and it came out recently in Developmental Medicine in Child Neurology, and I can send Doug those links to you. And it has more specifics about the outcomes and the tools. We chose some off-the-shelf validated tools of quality of life. And I'm happy to participate in another webinar one day around quality of life tools for children across the scope of chronic disease and disability. But yeah, for children with low communication, tools that look at those constructs can be a challenge. So I think that's what's behind that question. I get asked a lot.
And Dr. Major, don't hesitate to jump in on any of these questions as well if you have anything to add, for sure.
Yes, thank you. Yes.
And be careful what you offer, Nora. We may take you up on that. That whole issue of quality of life and measuring quality of life has been, a real sort of something people have striven for years, both in our acute care hospitals, but also particularly in our rehab hospitals. I know you've participated in the past in some of our work related to our data collection around rehab services and what's now our pediatric rehabilitation reporting system and PERS, which has a big focus on trying to measure improvement in function, outcomes of services related to function and the ability to participate in community activities, and attempting to effectively measure that. And in addition to measuring quality of life, we haven't cracked that yet, but that's so we may take you up on that at some point to see if we can learn more about actual objective measurement for quality of life.
Yeah. On that note, if it's all right with the group, I'll move forward with the part of the talk around what we're trying to, how we're trying to engage with the community in the development of these tools. So the next slide is around what the proms or the prems might look like. And so the questions that I'm about to put up, I can't emphasize enough, are not the questions. And this is not the tool. I'm just kind of illustrating how it might look at the end of the day. So for example, typos, please excuse. At the end of the day, what we're trying to do is we're trying to map out a continuum from the very negative, the most negative part of the experience to the most positive side of the experience. And when we do that, then we have the capacity to go out and validate the tool so that it has measurement properties, right? So that we have a true ruler, a true metric that gives us information about how people feel they are doing. So for example, if you look at these questions, again, they're not this is not validated in any way. These questions came off the hip a couple months ago before we started to get our qualitative framework, but they're just potential questions around how someone could be doing in a positive way. You know, I feel confident about using all the equipment I need to feed on the go. You know, that could be a really high level, positive level of experience around managing a G-tube, all the way down to a negative experience like I feel very frightened, I won't know how to resolve technical problems, there's no one who can help me with this, I take some runaround solutions in order to manage, I feel unprepared to do this. Questions like that represent the more negative end, right? But we want to develop a whole trajectory of what this looks like. And so we're about to, as soon as we're done the qualitative, we'll have to go through this rigorous validation process to get the prom or the prem ready for implementation. And so we're showing you this now because there's all these decisions we have to make around the validation of the tool. And we wanted to engage with the families, and we started engaging with the families, but also engage with their providers on what their kind of wishes might look like. Okay, so when we're talking to you because we want your ideas and we want your help. The statistical analysis hopefully will be looking for partners who want to try out the tool in order to get some validation. And we will be looking through all kinds of different methods of eliciting partnerships, but also families being able to answer these surveys. So on that note, we have a little video that we would like to show that kind of breaks down some of these, some of the things we have to figure out before we start validating the tool or eliciting validation for the tool. And this video was designed to elicit caregiver feedback, but just replace caregiver in this video with a provider of children to provider to children with medical complexity. And really, the same principles apply. So I thought maybe Doug or Andrew, you could help me bring up this 30-second video. Thank you. So we'll go back to the presentation. So you can't click the caregiver link, but at the bottom of this presentation, and I think it's going to be shared also, you can go straight to our Facebook page to see that video again or to share it. And you can also see some of our lay summaries of the research that we've done. But what we're really hoping for today is to get some feedback from about how you think this tool should look. There's questions in the survey. It takes about 5 to 7 minutes. It asks you about how long this survey should be, how the results should be used, other aspects of that we really need to think about before we get started with validation. I'm just going to go to our last one here. So really, we're taking a lot of time and putting a lot of time and thought, not into just what proms and prems we are developing, but how they should look in order to represent the care that providers give and the things that families think are important to them and measure it well. So if these tools don't ask the right questions, important aspects of their experience that are important to them might not get addressed. Again, these are not designed to replace clinical assessment, but just to enhance evaluations so that down the road we have detailed, systematically collected information about the patient experience and how to improve it. And I think that is a destination where we all want to get to. So, Dr. Major, if there is any other comment that...
I just want to wish to highlight the work in the development of this evaluation process for the care coordination and the change in the delivery of health. It's really multifaceted, and this specific area has been a great learning experience for all of us involved as well, and it's very nice to see the evolution of this work. So we're very happy to receive feedback and thoughts on this work that has been done so far.
And with that, we do have just a couple minutes left. So if there are any other questions and or comments, if you have any suggestions that you think might be of value to our team here, please don't hesitate to type those into the question box as well, and I'll be happy to share them with the audience. The one question that did come in back when we were going through the results that we didn't get to, someone asked if all the children that were responding were able to contribute their own experiences during the interviews. How many were nonverbal or required substantial support in order to respond? Can you give us a sense of what that looked like?
Sorry, I'm just adjusting my microphone. This is Nora here. We didn't actually interview any children. Sorry if we didn't make that clear. We interviewed their caregivers. So the inclusion was based on the children, but the interview was directed at the caregiver. And one of the children, I would say one of the children had the capacity to provide some feedback through an interview. The rest, it probably wouldn't have been appropriate to interview them by traditional means. The hope is that we, when we develop the tool, we could enhance the questions through augmentative communication, but that is one aspect of scaling it that is so many steps in advance. One of the questions we did ask caregivers is to talk about, from their child's point of view, how they think they perceive it. So that, you know, they would talk about, this is how this is how frustrated I feel with feeding or whatever. And then we would follow up with, okay, that's how you're feeling. Can you tell me a little bit about what you think your child would think if they could express themselves to us right now? What would their perspective be? So we're trying to elicit both perspectives, but we are limited in that most of the time we're talking to caregivers.
All right. We did have a couple of questions about access to the presentation and slides, et cetera. I just want to remind everyone, we do record these presentations, and you will get a link. Those of you that are registered here today will get a link to the webpage where you can find the copy of the presentation as well. So with that, I don't see any other questions. So and it is 12 o'clock. We are out of time, so a great time to wrap up. I do want to thank you, and I just want to hand it back to the both of you. If you'd like to just share any closing comments, key messages that you'd like to leave the audience with, just announcements of upcoming work that people might want to keep their eyes out for in relation to this area, events or anything else that anything that you'd like to share the audience with, before we sign off.
Dr. Major, you first.
Well, one thing that through this work that has been highlighted to us has been the family, the impact on the family, and their health both from a medical perspective as well as mental health. And this has further led to other type of research that we're doing with other organizations across Canada. It's called the CSENT. So it's called the Coach Coordinated Enhanced Neonatal Transition work, during which we are attempting an intervention by which nurse navigator who helps family to coordinate their healthcare needs and services, but also imparts family with skill sets of coping differently in face of stress, anxiety, and the mental health issues. So more to come, but certainly this kind of work has allowed to hear from the families, patient experience, and the other areas that we do need to seek out to intervene and evaluate.
Thank you. This is Nora. Just wanted to remind everyone that check us out on our Facebook page if you wanted to see any more detailed information. Please get in touch with me if you wanted to answer the survey and you had some difficulty. And my email is there if you are interested in having a discussion about the measure. And I direct more any questions around implementation with regards to CCKO to my colleagues who are providing service and who are more involved with implementation.
All right, and thank you very much for that. And as you mentioned, the link to the survey is also in the chat box. It's in your little control panel, and we will also, in the email that all the attendees today receive following this, we will make sure that link is also included in that email that they'll receive in a couple of days. That it also includes information about the recordings, etc. So hopefully we'll get lots of response or support getting some response to your survey for you, and we'll help contribute to continuing this work. So thanks again for joining us today. Great presentation. Thanks again to the audience for joining us, as we do every Wednesday at 11 a.m. Eastern Time. And when you do watch live, you do get to contribute your comments to the discussion. But as I did just mention, we do record these sessions. If you can't make it to the live session, we record them and make them available after the fact on the Knowledge Exchange Network at ken.childrenshealthcarecanada.ca. Our next webinar next week, March 27th, we will be talking about medical assistance in dying and with respect to mature minors. And we're going to be hearing from Dr. Dawn Davies, also from CHEO in Ottawa, from their palliative care program, and Roger Nielsen's house in Ottawa here. And Dr. Davies is going to give us a sense of what's happening at the federal government level as far as advancing legislation in this area. Mature minors currently excluded from the current legislation related to medical assistance in dying. And there's been lots of conversations about including something in that regard. And Dr. Davies will also put this into context for pediatric health centers as to what they should be thinking about in preparation for any potential changes to the legislation, what the timelines for any potential changes in that legislation might look like from her perspective as an outsider. She's not with government, so she can't say, but she's been part of many of the discussions and is going to join us to share some of her insight on that very important and challenging issue for many in our community. So thanks again for joining us today. Hopefully we'll see many of you back here next week. All right, bye everyone.